So it's my great pleasure to introduce our first keynote speaker this evening. And how I met this doctor is a long story, but it involves with me the only flight that I've ever missed in my life. And I would just tell you, do not fly Frontier Airlines. All I can say is that they have old people using computers, and the two don't mix. And it's the only flight I've ever missed. But I took the lemons and made some lemonade and rented a car in Denver Airport and went to go and meet Dr. Rangan Chatterjee for lunch. And we had a chat. And at that point, he was excited about functional medicine and going to start his own practice. And what would you say? The serendipity came along and thrust him into a new trajectory for his career. And this trajectory for his career is going to do what him and Max and other people are looking to do, is to bring these ideas and these concepts to the masses in a really powerful way. So Dr. Rangan Chatterjee, I believe, is the doctor of the future. And to tell you what that doctor is and how they work and how they operate, I want to give a warm round of applause to Dr. Rangan Chatterjee.
So the doctor of the future. What should that doctor look like? And actually, what kind of healthcare system should that doctor practice in? Now, before I can answer that question, I think we need to talk about what does the doctor of today look like? Now, I work in the United Kingdom. I'm a general practitioner. And in the United Kingdom, this is what I see. The doctor today looks like this: tired, disillusioned, frustrated, and overworked. See, in the UK, at the moment, a third of GPs want to quit within the next 5 years. 70% complain of excessive stress at work, and 85% think their profession is in crisis. Is that the kind of healthcare environment that lends itself to good quality patient care? How about a doctor in the future where the doctor actually feels energized, motivated, is both inspired but also is inspiring, and actually, most revolutionary of all, loves their job? Is that not a better environment to deliver good quality healthcare? See, I've been in New York for a few days now, and I've been reading about one of your own doctors, a US cardiologist called Sandeep Johar. And he was writing and saying that I was approaching the midpoint in my career, and I realized that I'd become the sort of doctor I never thought I would be. Impatient, occasionally indifferent, and sometimes dismissive and paternalistic. Now, if I look back a few years ago, that was the kind of doctor who I was fast becoming. But thankfully, I managed to take a few steps that have brought me from actually that doctor today and somewhere a little bit closer to that doctor of the future. So what's my story? So I qualified from Edinburgh University Medical School in 2001. I was excited. I thought, this is great. I'm going to go now and help people and get them better. And I followed a career in specialism. I did my exams. I became a member of the Royal College of Physicians in the UK. And my chosen specialty was kidney medicine. But then something dawned on me. I thought, I don't want to spend the rest of my career just seeing the kidney. To me, rather intuitively, I felt that the whole body is connected, and I want to see everything. So much to my father's dismay, and he's a conventional MD, hospital specialist, I made the move from the prestige of being a specialist to the lower rungs, somewhat of being a generalist. But that was exciting for me because I thought I'm going to get to help people, get to build relationships. Well, certainly so I thought. A few years in, it was a very, very bitter pill to swallow when you realize, actually, I'm not actually helping that many people. Maybe, 15, 20%? It's very hard to know what to do with that because you've invested time, money, energy into your education. But then the turning point for me came a few years ago when my son, who was 6 months old, he nearly died. Now, he nearly died from a preventable vitamin deficiency. And I, as his father, as a physician, as a general practitioner, I didn't do anything about that. And there's guilt associated with that, but that guilt leads to action. It drives you on because, as James was saying, the difference between acute and chronic. Modern medicine saved my son's life, but modern medicine taught the specialists and myself nothing about how to deal with the chronic consequences of what had happened. So I needed answers. So I started looking. I started searching. And you know, the internet being what it is, you find out stuff. And you know, I thought there's a whole field of nutritional science, immunological science that we were not applying as doctors. I thought this is madness. And so for me, I came across to the United States and I trained with an institute here, and I kind of went back pumped up thinking, hey, this is the kind of doctor I thought I was going to be when I left medical school. So I went back, I thought, this is great, I know how to do my job now. But then there's obstacles. So you've got the system, the healthcare system, that the way it is currently set up, it rewards making quick diagnoses. It rewards production line medicine. It's much easier in the current system. And in the UK, we see maybe 50 patients a day in general practice. It is far easier to actually hand out a prescription than it is to actually take the time to deal with the root cause. Actually, you make life difficult for yourself. If you deal with the root cause, actually, you run late. And by the end of the week, you know, your stress levels are through the roof. So the system doesn't help. We had general elections this year in the UK, and every political party saying, we're going to find the £8 billion that the NHS needs. But they're pouring more and more money into a broken system. The system needs to change. I thought about my education. I thought, well, actually, we've been taught an acute model of care, a pharmaceutical model of care that we try and apply to chronic disease, and it frankly does not work. See, I've been thinking a lot recently about the concept of threshold medicine, whereby we can deal with multiple insults up to a certain point. But once we get over that line, we move from good health to poor health. And actually, it's not a one single magic bullet intervention that's going to get you back. You've got to tackle multiple areas. We know now, we've known for a long time, but the global burden of disease tells us that poor diet is responsible for more death than physical inactivity, smoking, put together. But what did I learn about diets at medical school? I learned to tell people to eat a low-fat diet, which is frankly not only inadequate, it's potentially very dangerous. I thought about the way I was trained, this obsession with the diagnosis. See, I remember being a student in the Royal Infirmary of Edinburgh in the corridor, and the professor says, patient comes in with A, B, C. What's the diagnosis? And you got the kudos if you're the guy who came up with the diagnosis. But I believe the doctor of the future is going to see the diagnosis as a signpost rather than the destination. See, take something like headaches or migraines, for example. You make the diagnosis. The doctor of today, you start applying your treatment regime. The first-line drug. That doesn't work, come back. You're given the second-line drug. That doesn't work, the third-line drug. But what about if the doctor of the future sees that diagnosis of migraine and takes a step back and goes, hey, what's actually causing this? I mean, I'm saying it, and I think this is just common sense, isn't it? You know, how have we got so far removed from that? It's just common sense. You know, is it a magnesium deficiency? Is it a food sensitivity? Is it stress? Or is it something structural? So it's a new way of looking at things. You see, in the National Health Service in the UK, it's our biggest employer. We've got 1.3 million people who it employs. But 700,000 of those, so that's 54%, are either overweight or obese. So in the country where I practice, the United Kingdom, you've got this bizarre situation where the people who are tasked with looking after the population, they can't look after themselves. Now, this problem actually is bigger than medicine. This is a community environmental problem. Sure, doctors being educated and giving the right advice would be a great start, but actually it's probably not enough. because we are products of our environment. Unless that environment out there changes, we're going to have big problems. I was also thinking that over the past 30, 40 years, there's been a misplaced focus, in my opinion, on getting care more and more specialized. You know, I alluded to that before. My father could not believe I was trading in being a hospital specialist for being a generalist. But there is a well-established evidence base that is expanding by the day that high-quality generalist care is essential not only to improving population health outcomes, but also in the sustainability of any healthcare system. See, I believe the doctor of the future is going to be proud to be a generalist, because it's only a generalist who's going to be able to put it all together and connect the dots. The patients we're seeing now, they're complex. Somebody needs to put it all together. And then I move on to technology. I sometimes think that the medicine I practice, the system I practice within, is very outdated, because in the UK, you still phone up and have to try and get through the lines to make your appointment with your doctor. I mean, it's madness, because in the UK, you know, in 16 to 20-year-olds, 95% use Facebook each month. Now, that was in 2012 when that survey was done. It's 2015 now. No doubt that has increased even more. So we need to get with the times. We need to adapt, both so we can improve efficiency, but also so, you know, maybe access people in remote areas, help them access their medical care. But technology is a double-edged sword, you see, because we need to harness technology and use it for our benefit. But as doctors, we need to understand that every single person who walks through our door may be adversely affected by technology. Whether it's simply the blue light that that device is emitting that's affecting their sleep, or whether it's the fact that people can't switch off these days because they're so hooked and addicted to their mobile devices. That's something I assess with every single one of my patients, but I can tell you, most of my colleagues are not doing that. And that needs to change. See, medicine needs to adapt. Medicine needs to evolve. We've all heard about the mismatch between our genes and our environment, and that mismatch being one of the drivers for a lot of the health problems we see today. But what about the mismatch between our medical education system and the healthcare needs of the population? See, that's a big mismatch, and that's a gap that needs bridging. So medicine does need to change. Somewhere along the line, modern medicine has lost its way. You now have the crazy situation where one of the pillars, as laid out by Hippocrates over 2,000 years ago, primum non nocere, first do no harm. Well, it is routine now, I'm sure it's the same here, where a patient can go in and see their doctor, and on the first consultation, they can be diagnosed with depression and sent out with an antidepressant. Now, not only are the benefits of a lot of these drugs, including common antidepressants, somewhat overstated, that's me being very kind, but the risks associated with them are very much underplayed. Now, this is not conspiracy theory. This is published side effects. The common antidepressants that we routinely give to people like sweets, yeah, they've got mild side effects like nausea and vomiting, but they can cause visual disturbance, movement disorders. They can even cause you to have an increased risk of suicide. Now, look, I appreciate that risk may be very small, but my point is this. How far wrong have we come when actually, instead of actually managing nutrition, lifestyle, things like cognitive behavioral therapy, things which, frankly, are harmless, but arguably have got more therapeutic benefit? I mean, something has gone wrong somewhere, and things need to change. But there's a financial urgency to change. There's no question about that. In the United Kingdom, we spend today £20 billion, so that's about $30 billion every year, on managing the direct and indirect costs of type 2 diabetes. Now, look, we hear these figures, whether it's 30 billion or 47 trillion banded around. I think we can become numb to them. But type 2 diabetes is a disease that is driven by lifestyle and environment. And we can prevent it and reverse it with lifestyle and environment. Yet we're spending $30 billion each year managing it. But if you take a step back for a minute, you think, how have we ended up here? But as well as the clear financial imperative, what about the moral imperative? What about the millions of lives that are being prematurely lost each year? The needless suffering by a lot of our patients and their families. What about that? What about the fact that when I was in medical school, I remember in the anatomy lecture theater, we were told in year 1, look around you, 1 in 4 of you will get cancer. And I thought that was pretty shocking back then. Now in the UK, it's already 1 in 3. And we're told within a few years it's going to be 1 in 2 of us. What about that? See, I believe that every doctor goes to medical school wanting to make a difference. They go there to learn how to make people better. But you finish med school with your ideals, and then year by year, those ideals start to get eroded away. So you're left with a sorry realization that actually you become very good at suppressing symptoms, but not so good at resolving the root cause. So I believe the doctor of the future is actually going to work in a brand new healthcare system. A system that allows them to have time with their patients and talk. That instead of being tired, they're going to be inspired. Instead of feeling frustrated, they're going to be motivated. Instead of feeling overworked, they're going to have a pretty reasonable work-life balance and show their patients that not only can they talk the talk, they can walk the walk as well. See, a doctor in the future, they may prescribe pharmaceuticals, but it will be as a last resort and only when necessary, because the doctor of the future is going to understand that lifestyle and nutrition is the bedrock upon which all treatment for chronic disease should be founded. The doctor of the future, they're going to embrace individuality in their patients and not be enslaved to the randomized controlled trial. The doctor of the future is going to value the therapeutic value of the patient-doctor relationship and actually realize that the patient's views are just as valid as the doctor's views. See, that doctor of the future is going to ultimately realize that medicine is art as well as science. But we can't wait any longer for that doctor of the future. That doctor of the future cannot be the doctor for the future. That doctor of the future needs to become the doctor of today. Thank you.
Thanks so much for watching, and for more great clips like this, please subscribe to our YouTube channel. I've created a special free video just for you. It's called the 5 Steps to Becoming a Leader in Your Wellness Community, and it'll give you some of the starting points on how to position yourself as the leader in your zip code of your health community. All you have to do is click on the link below.